Let's take a closer look at the typical journey of a patient with inflammatory bowel disease, IBD. The journey is highly variable and unique for most patients with IBD. However, there are general stations, steps, or situations that are common or bear significant resemblance. It all begins with the appearance of symptoms. Initially, these symptoms may be downplayed, but their persistence will lead patients to either continue to downplay or ignore these symptoms, or seek medical attention. Unfortunately, some patients may underestimate the severity of their symptoms. This can lead to incorrect assessments of the potential seriousness of their disease or a lack of proper healthcare coverage, resulting in delayed treatment. For those who receive proper medical evaluation, various tests such as fecal calprotectin, abdominal scans, MRIs, and/or endoscopies, colonoscopies are considered. These tests are essential to establish the proper diagnosis and guide future treatment options. Following the diagnosis of IBD, a chronic disease, two different scenarios may unfold. Some patients may experience stages of denial, or may ignore treatment recommendation, or seek alternative therapies or second opinions. They may even turn to online resources like Google MD, or intentionally or unintentionally get lost to follow up. Denial, doubt, discussions about risks and benefits, and concerns about potential adverse events or cancer risks can overwhelm patients, leading to psychological distress, which may lead to disease progression. Here, the role of the family and/or patient support program is paramount to improve patients' acceptance, facilitate uptake of treatment, and minimize the mental health burden. In other cases, patients may accept their diagnosis and engage in conversations about the disease. They seek additional information about the benefits and risks of medications, often requesting educational materials or joining patient support groups. Upon confirmed acceptance of the disease, the treating physician can initiate a treatment plan. This plan may involve either surgical interventions or medication, each with its own interlinked pathways. The decision can be complex and require proper patient education and shared decision-making to improve outcomes. However, access and cost of treatment can significantly impact the patient's journey. Some patients may opt for surgery, explore clinical trials, end up with a suboptimal or even forego treatment altogether, leading to disease progression or loss of follow-up. Medical therapy or surgery can have both psychological and physical impacts on patients, while pharmacological treatment offers various therapeutic options, such as steroids, 5-ASA, immunomodulators, biological therapies, or small molecules. An important aspect of medical therapy is risk mitigation in order to minimize the risk of infections and/or other complications. This includes providing patients with proper education and updating and completing vaccination requirements. Once patients accept their chosen treatment option, they begin the journey of treatment. They are periodically assessed for responses, complete, partial, with or without adverse events. If necessary, adjustments to the treatment plan are made to ensure best chance of response and to improve or normalize the patient health-related quality of life. The journey is to minimize disease impact on physical, psychological, and social domains. Unfortunately, this might not be achievable in all patients, and a customized or personalized treatment approach is required. In conclusion, despite the hardships and mental health burden that accompany the patient journey, a patient-doctor relationship built on trust, education, family support, and patient advocacy groups create a favorable environment for patients and their disease journey. Through education, patients gain knowledge and empowerment, while support from loved ones offers comfort and encouragement. Patient advocacy groups foster a sense of community and provide resources for shared experiences. Together, these factors create a network of care, compassion, and understanding, guiding patients toward resilience and optimism and leading to improved outcomes. Let us continue to educate, support, and advocate, ensuring that no one faces their IBD journey alone.
level IV infliximab were therapeutic at 16 micrograms per mil. And then COVID happened, and like many of our patients, they got worried. They decided to have that conversation with their physician and discontinue the infliximab. So it was around about August 2020. And of course, the physician was a bit nervous, patient was a bit nervous, but he had enjoyed around about 3 to 4 months of disease-free time. And they said, okay, let's monitor, and if it comes back, we'll restart infliximab.
So do I understand,
Sure.
Nabil, that the main reason to discontinue was being afraid of more infectious issues, or
So
was it the
yeah,
access to the
so
hospital?
yeah, no, it was there. So I looked back at the notes, and I contacted his provider, who he was under in 2021, and he basically says, yeah, it was during COVID. He had a family member who became unwell, was hospitalized. He himself got COVID, and around that time, he said, right, I want to take a break. They had a discussion about whether to stop the captoprene or the infliximab, and then they decided to stop them both clean.
Okay, thank you.
And then in November, so that was in August, so literally 2 to 3 months on, he had rapid disease relapse, and went back to his physician, abdominal pain, restarted infliximab, and there was no improvement in disease activity. He stayed on it for a bit. I think they dose intensified from 5 to 10 and then went up to 6 weekly. Didn't make much difference. TDMs weren't checked, at least if they were checked, they were not recorded anywhere in his notes. So we don't really know what happened, what was the reason for his lack of response to reinduction with infliximab. Again, moved to another provider, and one of the things we'll see in UAE is that patients, if they fail a treatment, they'll find another doctor who put them on another treatment, and then they move to another doctor. And that's what he did. Basically, went around jumping from one person to the other, and then when he went to this other person, again, levels weren't checked. He was switched to ustekinumab at that point. His MRE was done, and he had fairly severe stricturing according to his notes, so I don't have any imaging to show. But surgery was recommended at that point. He had then again had obstructive symptoms, abdominal pain, occasional vomiting, but he continued to lose weight. Ustekinumab at that point was the only drug that was there. We sort of got risankizumab later on in late 2022, so around about December 2022, early 2023. At that point, they said, well, let's carry on doing this. There was a discussion about switching to vedolizumab, but they decided against that. They said, let's intensify ustekinumab, add prednisolone, add azathioprine. Didn't do much. 2 months later, I had a scan, and that was done at another facility where, again, it showed a fairly severe distal ileal thickening, possible ilio-ileal fistulation, and intense wall enhancement.
May I again ask a question, Nabil? What was the reason to add the prednisolone? And wouldn't there have been an alternative going for a more local acting steroid if you want to add steroids?
Yeah, yeah. I mean, so again, I was referred this patient mid last year, so
Yeah, yeah,
actually 2024. So I think I can only go with what was documented, and
yeah.
a lot of these providers were not contactable. But I understand at that point, he was very sick. They were trying to avoid hospital admission. They added
Okay,
in prednisolone, and they wanted to see how things go for a bit. But clearly that failed because
okay.
within 2 months he again presented to a different
And,
provider
and
All
with
right.
this.
may I ask you, in 2022, there was already a surgery recommended, but there
Yes.
was not performed. I assume that they, from May to November, did they change provider or did they refuse surgery?
He refused. A lot of our patients refuse surgery. We rarely do primary resections here anyway, and so let alone for worsening disease. Patients will like to cycle between biologics, and surgery ends up being, unfortunately, the last resort. Often stoma is discussed, and often most of our patients will end up with an ileostomy, and that's their biggest fear, and that what makes them surgery averse. So I think this is the reason why he basically said, no, I'm not having surgery. Let's carry on with the medications. I'll take some steroids.
Mhm.
I'll see how he's going. And he kept smoking during this period. Unfortunately, again, you'll see a lot of documentation in my presentation about smoking, and we've had discussions every meeting, every consultation, referrals to smoking cessation clinics. He knows it is clearly a bad prognostic factor for him, but unfortunately, that's a no-win situation for us.
Okay.
Okay, that was in November. January, he had that image done. Eventually, in February, he ended up having a semi-elective ileocecal resection. They took out 30 centimeters, so this histology report was accessible and the operation notes. So he had a 30 centimeter active disease. There was no fistulation seen, at least on the histological specimen or intraoperatively. But a side-to-side functional end-to-end anastomosis and granulomas at histopathology. There was no mention about his margins on the histopathology. It did say that margins were clear, but it didn't really say by how much and whether the granulomas were seen at the point of the margins. He has a CT done in May. I think he had a prolonged stay. I've taken a bit of his post-operative history and for the sake of time, but he had a post-operative ileus, had a CT done around about May. There was at that point no radiological evidence of Crohn's recurrence. So around about July, I think, as he's thinking and doctors thinking about doing his post-op surveillance scope, he has that done. And unfortunately, he's got active disease. Root guts are not reported. We don't have the imaging. All it says is that diffuse near-terminal ileal inflammation. So the subsequent month, he gets started on risankizumab, and he has some improvement initially. Again, that's what he says, the patient says. There's no actual documentation of a HBI or a PRO2 score. But he says he improved a bit post-induction. His CRP will remain a bit high. Again, I'm going to go through the inflammatory markers in a second. He stayed on it on standard dose, so standard induction, standard dose till June next year. But again, up and down, symptomatic relapse, abdominal pain, had a further colonoscopy, which shows an anastomotic ulcer. It says everything's normal. I'm not sure how accurate that report is because his MRI scan showed fairly diffuse mid and distal ileal thickening up to the point of the anastomosis.
Retrospectively, if you go back and it would have been your patient, would you have had another post-operative approach in this patient? I think they decided to watchful wait.
So I think he had all the factors for early recurrence. I think I would have stuck him on a biologic as soon as within 4 weeks of his operation once he's stable, and then did an early post-operative surveillance scope. I think 3 months. And if there was recurrence, I think I would consider putting him back on infliximab at that point rather than Skyrizi. In fact, I'll probably put him in infliximab. But at that point, it was not clear why he was switched. He was clearly a non-responder or secondary non-responder when he was restarted on it. Whether it was started fairly late on his disease when he already had stricturing and whether it was worth re-challenging him at that point with infliximab. I think back in time, things may have been done differently. I know options were limited at that point as well. This is right around the time when we got access to risankizumab. And I think.
And would you, because that was another thing that I was thinking retrospectively, the ustekinumab didn't got a chance, I think, the same that we discussed now with the infliximab. So might also have been an option that just keep giving just continue the ustekinumab because there was no the disease was too much present once the ustekinumab was started.
Yeah, no, I agree. I think he had lots of options, but I mean, at the same time, I don't think Skyrizi was a bad option too. I think they switched the class, and although sequence data wasn't there at that point, and certainly there's no experience, was no published data on post-operative use of Skyrizi within a RCD setting. I think that was the option they had, and I think that's what they went with at that point. But I don't think he had proper post-induction assessments done because there was very little objective markers. In between August and June, I think they put him on it, and then he disappeared. He eventually came back to the provider reactively with symptomatic disease and abdominal pain. So I'm just keeping an eye on time.
Nabil, just two short comments. One, I think at this moment we have to admit that the clinical predictors of recurrence are far from accurate. So there are patients who, like him, are smoking and had penetrating disease that for several years thereafter will not flare. And that's why we are currently doing a study in Belgium, either putting a patient immediately on a biological versus endoscopic-driven approach, so that we will hopefully have data soon. And the second thing, sometimes indeed we also do the postoperative endoscopy somewhat faster, but 3 months is risky because then you might mainly see postoperative changes due to the surgery rather than recurrence. So mostly we stick to 6 months. In some situations where there are several risk factors, we will go for 4 months, but not earlier. That's
Not earlier.
but
Okay.
please continue.
Again,
Thanks.
just Mark, I know we
Voilà.
don't belabor the point, but I guess if it's the second surgery, etc., then you just go from the get-go, right?
But even there, I think it should be a discussion with the patient, because there
Okay.
is even there not enough evidence. If you have these 3 risk factors present, they're the only 3 risk factors that have been validated, that you can be 100% sure. And the question is whether you lose or your window of opportunity by waiting, let's say 4 months before your endoscopy and then start. It's a bit also depending on where you live and how easy it is to have access to the biological agents, of course.
Yes.
Great. So that was in June, and then in August, he had a rescue dose of 600 milligrams IV. The rescue dose is 1,200, but I think he was given 600. And they saw that CRP dropped from only 103 to 76. He had no symptomatic improvement, and so it was thought that both ustekinumab and both interleukins, not IL-23s, but interleukins had failed at this point and were ineffective. And then so they referred the patient over to SSMC, and then he came over at that point. But yeah, that's his history. So up to this point, partial response to adalimumab, remission with infliximab, relapsed following withdrawal. When it was restarted, it didn't work. Then ustekinumab probably started late and it failed, and then risankizumab started postoperatively, and he had active disease postoperatively, going from minimal disease to fairly significant disease and rising inflammatory markers. And then so we had a discussion in clinic, and I said, well, he had the best response with infliximab, so let's go back on it. So this is when I saw him, and then so yeah, I mean this was a discussion point, but that's what we did. I think I don't know if you've got time for this, but maybe we can move on and then come back to this later. But he had options at that point. This is again mid 2024. He switched to vedolizumab, not an ideal option considering he's already failed 3 biologics and has got fairly significant disease. Restart.
Can you tell somewhat more on the MRI? You mentioned ileal inflammation. There were no signs of penetrating disease or pre-stenotic dilation or other complications.
Nothing. It was just purely inflammatory disease, and
because with that high CRP, you
Yeah.
should certainly also exclude penetrating issues.
Penetrating disease. Yeah, no, there was no abscess. There was no intra-abdominal sepsis. He's a very interesting chap. So his disease, mirrors his CRP. CRP goes up, he's got symptoms. His CRP comes down, he's completely asymptomatic. Very easy to track how he's doing just purely on his CRP. And all his imaging has, at least from the time we were seeing him, has just tracked inflammation. He's not had fistulation or penetrating disease, and his disease has been pretty much distal ileal or neoterminal ileal going all the way up multifocal segments. He's got about 60 centimeters, starting from his anastomosis going proximally, and then multiple segments above that. But it has not, since his operation, been stricturing, just inflammation.
Okay.
Okay, so we had this discussion, and then we decided to put him on infliximab. Don't know why it's given away at the bottom there, but it worked. I mean, the first dose, he turns up to clinic and says, "I feel like a new man." It's I'm first dose of infliximab. He had a dramatic improvement. So we started him on IV induction.
How much was the dose at this moment? Was a standard dose 5 milligrams per kg, or did you start with a higher dose?
We give him 10. So we give him 10.
Yeah.
And then so he had 10 week 0, week 2. He did really well. Again, I'll show you CRP here. CRP, that was great. I mean, he went on to then subcut infliximab. We use a lot of subcut infliximab here. And he remained on properly dosed mercaptopurine throughout. And I thought that's it. We've done it. He's doing well, great. Went back to smoking, unfortunately, and then he turns back up in March. So September.
Just one question: do you do sub-Q infliximab because this is a quite severe patient? And how fast did you change to sub-Q infliximab? Did you give just week 0, week 2, and then you went to sub-Q, or did you went a little bit further with IV?
Yeah, so I think if you ask me now, my practice will be different in 2026 with infliximab. Probably would have kept a patient like him on IV until we know he's got sustained clinical response, good high trough levels. We find sub-Q infliximab works really well because it maintains that the high trough without the peaks. Patients prefer sub-Q here. Certainly, he prefers subcutaneous, and he's always preferred going on drugs like ustekinumab and risankizumab for that reason. He travels a lot. He doesn't like to visit hospitals. And so he said, I'll go for it. But in hindsight, I probably would have kept him on IV a bit
Did you
longer.
ever measure the serum level here
Yeah, we did. We did. I'm going
before
to.
switching, or just
No, I
just
think.
as
Yeah.
a rule of thumb, I think when you restart the
It's your
infliximab, we
target for
always
the
recommend to add an immunomodulator. What you did, he was put on mercaptopurine, and
Yeah.
to rather fast check the serum level at week 2
Yeah.
or week 6. To really feel whether there will be immunogenicity risk, yes or no. And if you want to go to switch to sub-Q, of course, there is also dependent to estimate a bit whether every other week will be sufficient. Certainly, if you start with 10 milligram per kg and you need maybe 10 milligrams per kg, you could wonder whether every other week will be sufficient.
Yeah.
Yeah.
No, I agree. I think if I could go back in time, I'd probably do that, check again. But that response, of immediate symptomatic improvement and biochemical improvement sort of gave me the reassurance we were on track with him. And so we just followed the standard treatment protocols. But then he disappeared again for a bit. It was difficult to get hold of him. We're trying to get him back to at least do some objective assessments, possibly even do a colonoscopy or a calprotectin, and check his levels. But then he turned up, eventually managed to check his levels, and his levels were subtherapeutic. He had high anti-drug antibody titers. And again, what I did then was double his subcut infliximab. And then again, if I could go back in time, I'd reinduce him with bucket loads of infliximab, probably 10 milligram per kilogram, 0.2, and then keep him on 4 weekly until we can try and rescue the drug and try and reduce the anti-drug antibody levels. But but that's what we did, and that's what happened last year, in 2024. He had a good improvement though, and then he relapsed again. And then he then turned up in A&E. We decided, okay, you know what? There's no point checking levels. I think we need to do something else at this point. So we put him on Rinvoq, and we said, okay, let's plan to keep you on extended induction for now because we have to apply in advance with the insurance companies. And we said, okay, right from the outset, unless he has a good response, we'll keep him on 3 months. Otherwise, we'll aim for 6 months on 45 milligrams. Quit smoking, according to him. I highly doubt it. He completed his vaccinations then. He already had done most of them anyway, but he hadn't finished his Shingrix second dose. This is what happened. So this is what happened from the time he started his infliximab. So his CRP went from 120 to 8 and then went back up to 80 following the loss of response. Intensification didn't work, 101. So we then put him on Rinvoq without steroids. So he started Rinvoq day 1, and it improved. He went from 101 to 39 and then 7. The CRP symptoms resolved. And we said, okay, great, let's get that calprotectin, which again he didn't provide, and let's get some imaging done to confirm it's working. And then we can decide whether we can step down to a maintenance dose or keep going with the extended induction. So 5 months on, doing well, but then symptoms start coming back. He gets intermittent abdominal discomfort. His CRP starts rising. Sorry, I've got only about 5-10 minutes, so I'm going to crack on. And then we do a scan. This is September last year. Again, severe multisegmental inflammation. Very similar disease every time when he presents. 65 centimeters from his neoterminal ileum, with further proximal inflammation above that, going up to his mid-small bowel, up to his jejunum. No stricturing or fistulation at this point. So then we said, okay, we've got to do something different. This is what the situation was. Extended induction. He's on 5 months now of Rinvoq. And then these are the discussions we had. Do we keep him on Rinvoq for longer? Clearly, that wasn't an option. He's already progressed on it. He's had a loss of response after a good initial response. Switch to a monotherapy of something else. Switch to guselkumab, which I wasn't sure because he didn't really respond very well to interleukins, and clearly he was a TNF responder. We wanted to stick to that mechanism of action, which is why JAKs probably worked really well for him. Add a second agent, which one? Surgical resection, but he had a lot of disease and really would need to find an agent. And this is all inflammatory disease, so surgery would not be ideal for him. Enrolled him in a clinical trial, and we were opening Sybarite, so Fimkibart at that point, and said we'll hold him off. But I wasn't really keen to put him on a placebo-controlled trial at that point, especially with his history of steroid response, according to him, was very poor. So we couldn't run him in with steroids in the induction phase. So this is what we did. We added guselkumab, and we said, okay, complementary pathways. Let's see if that works. Maybe we're blocking his TNF activity and is a bit of IL-23 blockade. See what happens. So didn't work. So September, we didn't give it long enough. He only had 2 weeks of guselkumab, and within 2 weeks he presented to hospital, worsening abdominal pain. CRP goes from 37 to 125. We got him admitted to hospital. And that's a CT scan, which again shows his disease got worse. This is 2 weeks into his first induction to guselkumab.
What was his diet at that moment? Did you put him on any diet?
Yeah, so he was on Modulin, oral Modulin.
Okay. For how much? 50% or 100, or was it exclusive?
It was PEN, so partial internal nutrition at that point. And then it was only here when he got admitted, we put him on EEN.
Cool. Yeah.
Okay, so this is what we did. We said, okay, let's stop Rinvoq. I think we need to do something else. Put him on steroids, and then we gave him adalimumab. We had a discussion then, phoned friends and everyone, and then said, well, what do we do? He had a history with Humira exposure. TNF works really well for him. Let's go back. Let's give him bucket loads of adalimumab. So we gave him 160 milligrams weekly for 4 weeks. So serine protocol, put him on EEN. So at this point, he was on guselkumab. Hydrocortisone, Rinvoq had washed out of the system by then, and 160 weekly of adalimumab, EEN, and we gave him Septrin prophylaxis. And he did well. He had a good response. So his CRP went from 125 to 13 during the hospital admission. So he stayed in hospital for a couple of weeks, and then he was discharged on oral prednisolone, EEN, adalimumab, guselkumab, and Septrin. 1 month after discharge, so we're seeing him on a weekly basis, doing CRPs on a weekly basis, because I'm a bit nervy. I think I was expecting him, things went wrong with infliximab, things will go wrong with adalimumab. We didn't add an immunomodulator. We're hoping that the other drugs he's on will help prevent immunogenicity, even if he did have immunogenicity to adalimumab. But unfortunately, when we checked his levels after the 4th dose of adalimumab, so he's on 160 milligrams weekly, he had no detectable levels.
Do you think in hindsight, because you nicely put it, I understand your idea of trying to join everything, but do you think in hindsight that maybe stopping guselkumab and adding an immunomodulator would have been an idea? Or because I also understand that you just started guselkumab, I think it was week 3 or 4 when you decided to add adalimumab. So I fully understand the idea. I'm just wondering, because there was already a pre-exposure to adalimumab, a history of immunogenicity for infliximab, might have been an option to do those as you nicely put it.
No, exactly. I think it was very early on, as you say, on guselkumab to say we need to do something. Certainly, we couldn't keep him on Rinvoq if he's starting a TNF. Again, the question, I think you may be able to help answer this is it only an immunomodulator combining with immunomodulator prevent immunogenicity with a TNF? I don't know what the data for immunogenicity from Vega trial shows. If you have a second agent, does that second agent play the role of an immunomodulator in reducing the risk of immunogenicity, as opposed to just it being an immunomodulator? I don't think we've got the data. Certainly when I looked it up, and we don't have the data to say, does guselkumab, step in, do its own thing as a IL-12 inhibitor, but also reduce your risk of immunogenicity with a TNF blocker. We don't know, and I think it would have been risky because again, we are putting him on steroids. We don't know whether Humira is going to work, and I didn't want to leave him without a agent that we've just started, because then we'll be sort of going back and front with the drugs. But I think this is a decision we took together, and I said, if this fails, then we'd be looking at, options outside standard of care. But this is what happened, and then we said, okay, well, let's stop. Adalimumab's clearly not doing anything, but he's not too symptomatic. Let's put him back on a maintenance dose of Rinvoq. I think we've got him in a good position. His CRP isn't that high, and I think he's just starting off on guselkumab. So we restarted him on low dose, well, not low dose, maintenance dose Rinvoq. Continued his steroid wean, and he continued PJP prophylaxis. And this is today. I saw him actually in clinic today. I mean, coincidentally, he turned up today and we got a repeat CRP done. And as HPI came down, he put on weight. He's eating well. Weight's probably gone up because of the steroids. He's quit smoking, but he spends time with his smoker friends. Told him to avoid that as well. And he's on 5 milligrams of prednisolone. He's had his synactin test today, so we'll hopefully get him off that. We did refer him to a geneticist, and we did a genetic panel on him for monogenic disease. We find a lot of monogenic disease here. It penetrates late. He has, in this part of the world, you have a lot of consanguinity. We have, a lot of first degree and secondary relatives with the same disease phenotype. So we do think a lot of our patients have undiagnosed monogenic disease, and I suspect if he does turn out to have one, we'd probably change our tack with regards to his management. It'll open doors to a lot of other therapeutic strategies, but this is where he is now. I think I'm eating into the time for the next talk. So I'm just going to summarize his journey so far. This is him today. His CRP today is 13. He is on 5 milligrams of prednisolone. He's on UPA, 30 milligrams. He's commenced his maintenance dose of guselkumab at 200 milligrams weekly. So no, 4 weekly. So he's completed his induction on guselkumab 4 weekly. And really, this is where he is. Of course, we don't know how he's going to be in a few weeks' time. His history has always been unpredictable. And I think we just have to be prepared with a plan if things go wrong. So this is really.
And what is that plan, Nabil?
Yeah, so this is my last slide. So my last slide is the plan. But this is now. I think my long-term strategy is he's doing okay. Stepping down to maintenance doses of guselkumab 4 weekly, but not Rinvoq. I think we'll keep him on 30 milligrams. He's going to come off his steroids, and we'll see how far we can take him. If he does have a genetic disease that's driving this, and I think we're going to get the immunologists involved, and open doors to treatments like abatacept or stem cell transplantation. But I think until then, he's doing okay. We're going to keep him going for now. But if he doesn't do okay, I've got a whole list of possibilities, and I think putting back on intensified dosing of both, I think that's not ideal. I mean, he's going to be on this treatment for potentially life, I think, and having those agents long-term off-label isn't a good option. Low-dose prednisolone, he seems to respond to steroids. I think what worked for him when he was admitted was hydrocortisone rather than the Humira we were giving him. May have worked, I think, because he never had any drug floating around. Or he may be okay enough because he does respond to steroids to get him onto the TL1A trial. And I think that's a good option.
Is it an option now that he failed quite a lot of therapies? Because most trials do not accept a full failure of more than 3 lines.
Yeah, that's a good point, actually. I need to check.
Might be an issue there.
From what I remember, they do have a cap. We haven't hit that cap with the afimkibart as yet. For the number of lines, we have enrolled a patient who's failed 5 lines of therapy, and so that was last year. So I don't know whether we've hit the cap with him. We are opening the other TL1A trial, the Starscape. So I don't know what they haven't as yet started.
Out of your whole list, I think one thing deserves already attention now, and that's the stem cell transplantation. I think you should now already start discussing with your patient, just that he's aware of it, can prepare for it if necessary. The other thing is, of course, he's on combination therapy with guselkumab and UPA. We think that guselkumab is a safer agent. Always also consider everything on vaccination, prevention of infections, and so on.
And there's a question that why do not try the combination of vedolizumab together with that anti-TNF or check I think we will see more and more data arising from the combination UPA-vedolizumab, more in UC. But I think it's might be interesting to consider. But I think the data for golimumab, it's not yet there for Crohn's, I think, and could be an idea to use certolizumab with vedolizumab, but I don't know if such a refractory patient we will see a lot of work coming from vedolizumab.
And the other point I have is, yeah, is it already suggesting that huzelekimab is better than all the other IL-23s that we have, as well as ustekinumab? And is 1 year, of course, but this is something we have to look into in the future, same as with UPA and the other JAKs.
Yeah. Have you experienced that? Have you find one of the IL-23s works better than the others in your experience?
I think for ulcerative colitis, there we see a difference between what we have and what we will have. For Crohn's, it's not clear yet, but we only have recent access to huzelkimab. I think the main advantage of huzelkimab is mainly the SQ induction, rather than stating at this moment that it's the most potent of the three.
Yeah.
And I think also our first experience with such as with any biologic coming to the market is the first patients that we put in with the early access program are mostly the most severe, failing several lines. So gives always a skewed idea on what the working is.
Joe, we will have to wrap up here. I don't know whether there are any other questions coming from the public.
I think we can wrap up and go to the second case. Thank you very much.
Thank you very much. And
Nabil,
thanks for your input. That's really useful. Thank you.
Yeah.
Okay, thank you. And it's a great pleasure for me to introduce our next speaker, which is Dana Ahmed Essa from the Jaber Al Ahmed Hospital in Kuwait. Dana, the floor is yours.
Okay, so I'm gonna get started with my case. It's a bit different from Nabil. We're gonna have a bit of a rough pathway until we got to the diagnosis of Crohn's here. So as you can see, it's beyond the gut pancreatic Crohn's disease as the first clue to underlying IBD. It's moving. Is it moving?
No.
Okay. My case. So Nawaf is a 24-year-old Kuwaiti male. I actually inherited this patient. So his journey started in September of 2023 when he presented with 2 years history of epigastric pain intermittently with vomiting and a significant weight loss of about 16 kg. He has no previous history of IBD, no chronic pancreatic diseases, no NSAIDs intake or alcohol use, no previous surgeries or any medical histories. He was not on any medications. He denied smoking and alcohol. He's a low student. And he does have a family history of Crohn's disease in his family of a paternal cousin. In September, when he presented in 2023, he had normal lab investigations that included his CBC, RFT, LFT, lipase, and lipase at the admission. GI service were consulted for his epigastric pain. And prior to his EGD, actually, that was the sequencing here is a bit off. But prior to that, I'm just going to move to the next slide. Sorry, here. He did have, sorry. I'm going to move to the EGD. So he did have an EGD done by GI service that did show multiple gastric ulcers involving the antrum and the body that were first 3, and then endoscopic features of gastric outlet obstruction. The pylorus was edematous at that time and ulcerated. The duodenum was not intubated. Biopsies from this endoscopy showed chronic gastritis with mild focal activity and chronic duodenitis, and there was no evidence of Helicobacter pylori infection or intestinal metaplasia, dysplasia, or malignancy. And after that, he was given a trial of 4 weeks H. pylori prior to the histology coming out because it takes a bit of time, 10 to 14 days to come out. He was tried on H. pylori empirically treatment, and a repeat of endoscopy was done that did show persistent gastric ulcerations, deformed duodenal bulb, and that time they were able to go and intubate into the bulb, but the D2 was not intubated. Again, a histopathology was performed, and there was a superficial biopsies reported as moderate chronic active erosive duodenitis and negative for malignancy again. So the suspicion of peptic ulcer disease was still there. He had a CT done at the same time that with a contrast that did show inflammatory thickening of the pylorus and proximal duodenum with mild upstream gastric dilatation without a discrete mass lesion. Findings were also consistent with an inflammatory process, and this was interpreted as a sequel of peptic ulcer disease again. So the patient did have persistent gastric outlet obstruction symptoms and refractory symptoms. So the patient underwent a gastrojejunostomy in October of 2023. His post-operative course was a bit active. He did have recurrent symptoms. Patient developed recurrent episodes of hematemesis. He had an ER visit and an admission, hospital admission. He had a CT angio that excluded active GI bleeding. He was treated conservatively and improved. Over the months, he experienced again intermittent abdominal pain with multiple ER visits and conservative treatment. In January of 2024, so from 2023, after his surgery up until 2024, he had multiple ER visits. Up until like 2025, he presented to ER with history of nausea, vomiting, abdominal pain, jaundice in this time, and dark urine. He was admitted as a case of obstructive jaundice. His LFTs were consistent with a cholestatic pattern. As you can tell here, the ALP, ALT, and AST were elevated. His gamma GT and bilirubins were also elevated. His lipase and amylase were normal. Remaining blood work was unremarkable apart from an CRP that was elevated at 67. He was admitted, had the investigations done. His MRCP was done, showed a focal inflammatory soft tissue described as a reaction, phlegmon and a mass along the posterior medial aspect of the second part of the duodenum near the pancreatic head, causing an extrinsic compression of the proximal CBD with resultant biliary obstruction as a cause of his obstructive jaundice. Based on that, he underwent a CT with a contrast to further evaluate this compression or extrinsic mass compressing the CBD. This showed a circumferential pyloduodenal wall thickening, periduodenal fat stranding, and inflammatory changes within the pancreatic duodenal group without a discrete mass of the pancreatic parenchyma, and there was no extrinsic mass compressing. A repeat EGD was done at the same presentation, no changes, the same findings were noted, pyloric thickening, edematous. Again, they were unable to intubate, but the biopsy this time showed villus atrophy and intraepithelial lymphocytosis, which raised the suspicion of celiac disease. Celiac serology was done and it was negative. So what to do with this patient now? He underwent serial abdominal ultrasounds, CT scans, biliary dilatation, gallbladder distension, and a bulky pancreatic head was noted in this CT with surrounding fat stranding, inflammatory process, and phlegmon formation denoting growth pancreatitis with possibility of a previous sealed perforation noted on the scans.
Can I ask you, because he had several CTs, the first one was already 2 years before. Then you didn't mention anything on the pancreas. Did you retrospectively look into that CT and did they confirm that at that time there was nothing wrong with the pancreas?
Exactly. So that was actually reviewed, and there was nothing wrong with the pancreas itself. They did report a mass, and that's why it was reviewed and a CT was done.
So, and he also underwent that gastroionostomy because of the gastric outlet obstruction. Did they resect part of the small bowel at that moment or not?
No, they
No.
just
So,
bypassed it, and
so
there
we
was
don't have pathology from a larger.
unfortunately, but
No,
during
okay.
this admission, actually, so in March he had this, and then he was actually discharged. He settled from a clinical perspective. He presented again in April, and at that time, actually, he presented with an acute pancreatitis, different than the obstructive jaundice now. So he came in with an abdominal pain, typical pain, radiating to the back with vomiting. He did have a normal LFT, RFT, and a CBC, but his lipase this time was around 3,600 with an elevated amylase and CRP. So he had actually a repeat endoscopy at that time, an upper endoscopy, and again, it did show the persistent pyloroduodenal structure with friable, ulcerated, and hyperemic mucosa. And this time we tried to go retro. This time I was involved and I was on service when he was admitted and consulted on. So we tried to go retrogradely from the biliopancreatic limb of the gastroduodenostomy in order to try and get to this stricture and obtain more biopsies and see if we can get more information from this part of the bowel. So again, the same inflammatory narrowing or stricture was noted. The biopsies again showed chronic active inflammation with chronic active duodenitis with reactive changes from the duodenal structure.
There is a request from one of our colleagues whether there was any reason not to perform an lower endoscopy at more early time points. I'm not completely sure what would have been a trigger to do so, I have to admit, because up to now nothing is suggesting, I think, an IBD or whatever from.
Exactly. So we were still working around chronic inflammation. Peptic ulcer disease was still a questionable presentation in him. So at that time, he actually got a colonoscopy, thinking about the stricture that he had, and had a colonoscopy done that did show normal, again, colon, normal TI.
And if I remember, there was also family history of Crohn's disease.
Correct. So he
with
did
an
have
upper
a
GI ulcerative lesions. You
Yes.
could eventually think maybe a calprotectin or whatever could have triggered doing an endoscopy more
Exactly.
retrospectively, of course.
The problem is that the calprotectin could have been high anyway, due to the higher, because it's quite specific, and it has been described that even in esophageal cancer can be high. So it would be difficult here to distinguish between the inflammation or Crohn's or so.
That's true. Unfortunately, the presentation wasn't the classical presentation when he came in. So and also that presentation, he also had a CT abdomen with a contrast and also showed a pancreatic, this time inflammatory process, compressing the gastric antrum, duodenal parts, and CBD with minimal central intrahepatic bile dilatation with mild dilated pancreatic duct. So there is something that we can.
May I ask a question?
Sure.
Dana, sorry, did we do at any point of time an upper EOS?
An upper EOS?
Endoscopic sound.
So it's cutting. I can't hear you.
And did we check IgG4 for this?
So it's coming.
Yeah. Did we check an upper EOS for this patient? And
Yeah.
did we check? Okay. And did we check IgG4?
Yeah, so it's coming now. So great questions. Yeah, so this was actually a working diagnosis here. So we're trying to think what's causing his. So now pancreatitis is the entertaining diagnosis, and there is a pancreatic inflammatory process happening there. So he actually underwent an EUS at that time that revealed the bulky hypoechoic pancreatic head containing the ill-defined inflammatory area that was biopsied. And the histopathology now came with the granulomatous inflammation at the pancreas of the pancreatic head that was biopsied. So again, the IgG4 was actually done as part of the workup for the granulomatous pancreas. So thinking about all the causes that can contribute to granulomatous pancreas, it's actually difficult to reach it because of it's not a typical presentation of Crohn's. So yes, and other causes of granulomatous pancreas were ruled out based on clinical, radiological, and laboratory evaluations. Infectious TB was done, workup was done and ruled out fungals also. Autoimmune, so sarcoidosis, his calcium was normal. He did have the ACE levels. He also had a CT, forehead vasculitis. P-ANCA was done, and the IgG4 was done and was also normal. And rheumatoid arthritis was also entertained, and that was actually ruled out. So on
Sorry,
follow-up,
of course, there
yeah.
was a clear time link with surgery underwent. Everything
So
started after
before,
surgery.
absolutely. So before that, we had an MDT that included our histopathologist. We also reviewed the pathology again. The images were reviewed, the surgeons were there, and we also had an external visitor at that time too. So all diagnoses were entertained and the images were reviewed, the histopathology were reviewed, and obviously all the cause of granulomatous pancreas were ruled out apart from the entertained diagnosis at that setting. We thought it's probably a Crohn's
Did you
disease.
find anything in literature whether
So there were case report actually with the same presentation presented with granulomatous pancreas and diagnosed as Crohn's disease.
but also
And
linked to surgery? I'm just wondering whether during surgery something iatrogenic might have caused issues at
oh no,
at the
no,
pancreas that then triggered on the long term a pancreatitis, because there is a clearly time link here.
yeah, no, actually there was no case report linking it,
No.
but the presentation, like similar presentation, but not linking it with surgery.
And Dana, a very nice case. I just before you finish off, I'm interested in that the patient primarily had really luminal disease,
Correct.
ulcer disease of the duodenum, and did not really have a pancreatic disease as such. His amylase lipase were normal. Previous imaging had excluded whether there was something in the pancreas. And clearly, I mean, his process looked like it started in the bowel and then sort of involved the pancreas somehow, but I'm not sure, where are the granulomas in the pancreas? Are they like in the between the acini? I mean, that would be very interesting if you had the pathology to show us.
So I don't have that pathology, unfortunately, but yeah, they were actually between the acini, and there were no other features of pancreatitis, as in like fibrosis.
I think Allah wants to see it as an image of the month in the New England.
Yeah.
And actually, the other thing, if you recall from the beginning of the case, there was no pancreatitis at that time. That's correct. They were normal and just obstructive jaundice. And the pancreatic head, which they reported as an external compression. So that was actually reported as the pancreatic head itself compressing the CBD. So the pancreas was abnormal to begin with.
I
You
know
know, can I make a comment?
Yeah.
yeah,
The question is, are we sure this is a pancreatic granuloma and the needle did not go through the duodenum and get a possibly Crohn in the upper GI? How
this is
can we
was a biopsy, I
100%
think, not
make
an
sure this is
FNA. You can, I think
duodenum?
this was a biopsy, right?
Yeah, that was a
Not
biopsy.
an FNA. So
No, sorry,
get
that's an FNA
pancreatic.
biopsy.
Yeah, yeah. I know this is an IBD conference, and that's why we think, of course, now we know that it's Crohn's, etc. But honestly, if you have a young person with gastric outlet obstruction with ulcer disease, you should think along those lines because peptic ulcer disease doesn't cause this anymore. I
Yeah,
mean, this is, I've,
exactly.
this used to happen in the 50s and 60s, but nowadays with wide access to PPI therapy, H. pylori eradication, I have yet to see a peptic ulcer disease in a young person presenting with an obstruction that doesn't open up. So I think there was already some kind of a hint that there's something weird brewing in this patient, and the family history, I think, is certainly supportive.
That's true. Yeah.
Yeah.
And actually, I did a bit of a review. So he was started on infliximab and methotrexate at that time. I tried to avoid putting him on Imuran just because of the risk of pancreatitis. Although looking at the case reports that were mentioned, that they were reported on the same or similar cases, they did use Imuran without any concern of pancreatitis. He did have a regression inflammatory mass effect on his images. He's doing well clinically. He did not present to the ER with abdominal pain and just following up regularly with improved clinical and biochemical status. Just a quick review. There's little evidence of pancreatic granulomas actually in the literature. And yes, there is an incidence of acute pancreatitis in patients with Crohn's disease, and it's actually higher than the general population. It can be induced by the drugs that we use to treat, but it can also be provoked by other diseases along with IBD, such as cholestasis or PSC. But actually, there were a few case reports that had no cause of pancreatitis other than Crohn's disease itself that could be identified on histopathology, again, along with EUS-guided biopsies and multidisciplinary clinical pathological correlation that puts the diagnosis and appropriate management together. So, and again, just like Prof. Ala just mentioned that refractory peptic ulcer disease and duodenal strictures in young patients weren't further evaluation for other causes, and specifically probably in our setting, IBD, not peptic ulcer disease itself, like nowadays.
Yeah, very interesting.
Thanks a lot. Nice, very nice case, and I think we can only suggest that you indeed do something more with it and publish this, because it's quite remarkable.
Indeed. And what was the evolution of the patient? Because I might have missed. Did he resolve fully, both luminal and the pancreas?
So he did get an image, and that did show a regression course of the inflammatory effect. He did not get a scope. He was refusing. We're trying to get there, but he did not get it because of the repeated scopes. But he's like, I'm clinically fine. I'm not coming to the emerge. I'm just going to postpone my scope. So hopefully I'm going to see him in the next few days, a few weeks, and try to convince him to come for a scope.
Okay.
Yeah, I think I mean I know Mark and Joao have seen many of the pancreatitis associated with Crohn's. As you mentioned, they're sometimes drug related, but often they are independent. They're associated with the IBD as such, whether autoimmune or not, and they can be recurrent. I have one patient who just had, recurrent attacks until he was actually put an immunomodulator. And we chose mycophenolate mofetil in that patient because of as you mentioned, the azathioprine issue is you'll never know what is causing pancreatitis. And the patient has done remarkably well on that. But I've never heard of really granulomatous pancreas in that case. Very interesting.
And the only cases I know are all IgG4 related, I think. So.
Yeah, and interestingly, his IgG level was 8, so it wasn't even high.
I think this is indeed, I agree with Mark, this is something that you should go further with once you have the images of the scope. Might be interesting to publish the case.
Oh, yes, I did actually write it up. So we're waiting for the follow-up scope, so to have it documented.
Put us in the acknowledgements if you reach out to doing it. Okay, I think we have to wrap up, but I leave that to Ala.
Yeah, thank you so much. Really very nice cases. I think Dana's case is really unique in many of its factors. I think Nabil's case is also unique partly, but I think it underscores the fact that we often, as we talked about last weekend, we have this chaos theory in terms of management and mixing things up, and we don't know what to use and when to use it. And I think we need to make sure that patients are not, they don't shuffle through biologics very quickly and burn their bridges very rapidly. And of course, in that particular patient, I think COVID really caused a lot of these issues. I want to thank everybody. I think the chairpersons, thank you so much. Very interesting presentation. And I think Nancy is going to share with the audience the next date for the next meeting, which will be in April. So looking forward to see you all. And I want to take this opportunity again to thank Johnson & Johnson for their support, and see you soon.
Thank you very much. Bye. Have a nice day.
Bye.
Bye.
Thank you. Thank you.
Let's take a closer look at the typical journey of a patient with inflammatory bowel disease, IBD. The journey is highly variable and unique for most patients with IBD. However, there are general stations, steps, or situations that are common or bear significant resemblance. It all begins with the appearance of symptoms. Initially, these symptoms may be downplayed, but their persistence will lead patients to either continue to downplay or ignore these symptoms or seek medical attention. Unfortunately, some patients may underestimate the severity of their symptoms. This can lead to incorrect assessments of the potential seriousness of their disease or a lack of proper healthcare coverage, resulting in delayed treatment. For those who receive proper medical evaluation, various tests such as fecal calprotectin, abdominal scans, MRIs, and/or endoscopies, colonoscopies are considered. These tests are essential to establish the proper diagnosis and guide future treatment options. Following the diagnosis of IBD, a chronic disease, two different scenarios may unfold. Some patients may experience stages of denial or may ignore treatment recommendation or seek alternative therapies or second opinions. They may even turn to online resources like Google MD or intentionally or unintentionally get lost to follow up. Denial, doubt, discussions about risks and benefits, and concerns about potential adverse events or cancer risks can overwhelm patients, leading to psychological distress, which may lead to disease progression. Here, the role of the family and/or patient support program is paramount to improve patients' acceptance, facilitate uptake of treatment, and minimize the mental health burden. In other cases, patients may accept their diagnosis and engage in conversations about the disease. They seek additional information about the benefits and risks of medications, often requesting educational materials or joining patient support groups. Upon confirmed acceptance of the disease, the treating physician can initiate a treatment plan. This plan may involve either surgical interventions or medication, each with its own interlinked pathways. The decision can be complex and require proper patient education and shared decision-making to improve outcomes. However, access and cost of treatment can significantly impact the patient's journey. Some patients may opt for surgery, explore clinical trials, end up with a suboptimal or even forego treatment altogether, leading to disease progression or loss of follow-up. Medical therapy or surgery can have both psychological and physical impacts on patients, while pharmacological treatment offers various therapeutic options, such as steroids, 5-ASA, immunomodulators, biological therapies, or small molecules. An important aspect of medical therapy is risk mitigation in order to minimize the risk of infections and/or other complications. This includes providing patients with proper education and updating and completing vaccination requirements. Once patients accept their chosen treatment option, they begin the journey of treatment. They are periodically assessed for responses, complete, partial, with or without adverse events. If necessary, adjustments to the treatment plan are made to ensure best chance of response and to improve or normalize the patient health-related quality of life. The journey is to minimize disease impact on physical, psychological, and social domains. Unfortunately, this might not be achievable in all patients, and a customized or personalized treatment approach is required. In conclusion, despite the hardships and mental health burden that accompany the patient journey, a patient-doctor relationship built on trust, education, family support, and patient advocacy groups create a favorable environment for patients and their disease journey. Through education, patients gain knowledge and empowerment, while support from loved ones offers comfort and encouragement. Patient advocacy groups foster a sense of community and provide resources for shared experiences. Together, these factors create a network of care, compassion, and understanding, guiding patients toward resilience and optimism and leading to improved outcomes. Let us continue to educate, support, and advocate, ensuring that no one faces their IBD journey alone.